So we're going to talk about retina versus neuro-op. Of course, neuro-op's better, but sometimes we get referred retina cases masquerading as neuro-op. And the reason is the two patient populations are quite similar. So a prototype patient might be a 20-year-old, previously healthy white female, and her complaint is going to be decreased vision. She may or may not have a little RAPD, and we might have a normal fundus. And so this stem, acute unilateral loss of vision, RAPD, pain with eye movement, and a normal fundus in a 20-year-old white female, that is the stem for optic neuritis. And the most common cause? Multiple sclerosis, but sometimes it's idiopathic. But what if we just add in a few little things? Then this stem would convert from a neuro-op case, optic neuritis, to a retina case. And so differentiating these two is going to require symptoms, signs, and then tests. So what are the symptoms that would suggest that this is retina and not neuro-op? All of these are going to be the same. But one of the key things that separates optic neuropathy from retina is photopsias. Now, photopsias can occur in optic neuritis, but if the predominant complaint is flashing lights, that's kind of a retina thing, flashing lights. In addition, they might say it's worse at night, nyctalopia. Or it's worse in the day, hemorrhaginopia. So if we have hemorrhaginopia or nyctalopia, day blindness or night blindness, those are really symptoms that match with the retinal photoreceptors. Because the optic nerve really doesn't care that much whether it's day or night. But the rods and the cones, it cares whether it's day or night. In addition, as opposed to optic neuritis, which normally produces a central scotoma or a nerve fiber layer defect because it matches the pattern of the nerve fiber layer, retinal problems cause paracentral scotomas that look like the shape of a ring, and we call that a ring scotoma. And that's because the parafoveal area, so we have the macula and then the perifoveal area, then we have the fovea, and in the dead center is the foveola and the umbo. When retinal disease likes to affect the parafoveal area, and so that means it might spare the acuity, then a ring scotoma, and then spare the periphery. So when we have a ring scotoma, that's also a sign that maybe this is a retinal problem. And then finally, the fundus is normal because some retinal problems are occult. And the prototype is an acute zonal occult outer retinopathy. It's called occult because the fundus is normal. We don't see anything. New innovations have occurred that allow us to see the retina at the micron level, however, and that is called OCT. So whenever we have a normal fundus, we're going to do an OCT, not only of the optic nerve, but of the macula. Because what we're going to be looking for in that OCT of the macula is each of the layers in the layer cake, from the retinal nerve fiber layer to the retinal ganglion cell layer, all the inner layers, the middle layers, and the outer layers. Because even though acute zonal occult outer retinopathy is what I would call all of these normal fundus people, now that with OCT we know that some of these zonal retinopathies are actually the inner retina or the middle retina, and some are still the outer retina. And OCT can tell us where the hyperreflectivity is and where the thinning is in inner, middle, and outer maculopathies. And so retina has named these like this: acute middle maculopathy, or it might be inner maculopathy or outer maculopathy, depending on where we see the problem in the OCT. And ultimately, we sometimes have to do electrophysiology to confirm that the retina looks normal but isn't normal, and that's a multifocal ERG. So the electrophysiologic study will show that the ERG is decreased, but only in the middle. So we would not be using full field flash ERG in this setting. Multifocal is what we use for the center vision. So in this 20-year-old white female who has loss of vision and RAPD and a normal fundus, yes, it could be optic neuritis. Yes, we're going to do an MRI looking for demyelinating plaques of MS. But what if there are predominant symptoms of retina? Photopsias, nyctalopia, hemorrhaginopia, a ring scotoma. Then we're going to deploy the OCT. If we see the pathology on the OCT in the inner, middle, or outer macula, we might confirm that with an MERG. And now this case goes from being neuro-op to being retina.